This is a recorded lecture on Chapter 20, which is Medical Emergencies, that starts on page 241 of your patient care book. First thing we start off is to define a medical emergency, or just an emergency in general, which by definition is any situation where the condition of a patient or a sudden change in their medical status requires immediate action or immediate attention. Okay. Typically, as a technologist, we generally have the objective of preserving life, avoiding further harm to the patient, and getting appropriate medical assistance when necessary and as quickly as possible. We also have to be able to recognize an emergency situation and initiate the proper emergency measures, whether that means hitting a code button or calling a rapid response or just enacting some kind of emergency measures where we contact someone with more authority. As far as priorities, what we need to attend to are to make sure that there's an open airway, control any bleeding that is taking place, want to make sure that we take measures to prevent or treat the patient going into shock, attend to any wounds or fractures, provide emotional support, and reevaluate and follow up appropriately with the patient. One of the first things we need to be able to recognize is where to find a crash cart or an emergency cart. The picture of this is actually on page 243, and you can see this picture that they have here, where it's typically just a cart that is found either in the hallway or some rooms in the department. Typically, it can either be gray or red in color. Typically has locked drawers on it, and the key is usually in the radiology manager's office or somewhere that is accessible by the technologist. The crash cart typically has equipment and medication on there that is used in the event of an emergency. Everyone should know where this is located or where they are located, so that if there are patients that end up in an emergent situation in the radiology department, someone can get that crash cart, and that way the nurses and physicians have the ability to attend to the patient quickly and appropriately with the proper equipment that is needed. They reference that having that emergency equipment readily available and the drugs readily available that are in this crash cart reduces the time required to respond to a medical crisis. As far as locating the emergency equipment, you want to make sure you know where the emergency cart or the crash carts are in the department. You want to know how to put a patient on oxygen or where to find that oxygen, whether it's wall unit or portable units. You want to know how to operate the wall-mounted suction, and you also want to make sure that you know where the AEDs, the automated external defibrillators, are in the hospital setting. You want to be able to locate those and get them if they were needed. Some emergencies we might see in radiology could be that a patient goes into shock. We could have anaphylactic shock from contrast media injections. Patients could have a pulmonary embolism. They could go into diabetic reactions, cerebrovascular accidents or strokes, cardiac and respiratory failure. There could be syncope, which is fainting, and patients could have seizures as well. These aren't the only emergencies that might come up, but these are definitely some of the more common ones that we tend to see. As far as head injuries, they talk about that when patients have head trauma, a lot of times they come to the emergency room and they're seen in radiology as for skull x-rays or facial bone x-rays. And it's not our job to diagnose a head injury, but we do need to have a knowledge of the categorization that's used so that we can assess the patient when we get them and know any changes in the patient's either level of consciousness or their mental status. So when we look at that, you want to assess where the patient is when you get them. Their clinical symptoms might not manifest right away, so you want to make sure that you evaluate them as soon as you get them, and then periodically thereafter. They could have a hematoma, which is bleeding, They could have brain swelling, and typically they will go to CT as the initial modality for assessment, but it is possible that if it did not present in there, they could be in the radiology department when that happens. There are different levels of consciousness that they mention on page 243. The first level would be where the patient is alert and conscious, knows where they are, can respond to who they are, what day of the week it is, who's the President of the United States, simple questions like that. When that would be the first level. Second, they could be drowsy, but they respond when you stimulate them. Whether you tap them or you call their name, they tend to respond to you. So that is the second level. The next level is where they're actually unconscious and they only react to painful stimuli. If you were to pinch them, or sometimes they'll prick the bottom of their foot with a clean needle, things like that. So they're relatively not conscious unless you give painful stimuli, and then they tend to react. And the worst and most serious level of consciousness would be if the patient was completely unresponsive and they were comatose and they did not respond to any stimuli. The bottom line is you really need to know your patient. You have to assess the patient at the beginning of the procedure so that you know what they were like when you first got them. You don't want to confuse a head injury with intoxication, meaning that you don't want to assume that because they were intoxicated and they did have a head injury, you don't want to assume that their change in consciousness level is because of the intoxication and not the head injury. You just want to assess them and go with your findings. You want to note any signs of deterioration from one level of consciousness to the other and pass that on to whoever is required to know, their physician, the nurse that's taking care of them, whoever that happens to be needs to be made aware of the change in condition. Times when they have a deteriorating head injury, they will become irritable, lethargic, they have a slow pulse rate, and a slowed respiratory rate. As far as level of consciousness, you want to ask the patient to state their name, ask them what day it is, what day of the week, their address, why they're in the radiology department, why they came to the hospital, and see if they can answer those simple questions. When you're instructing your patient in how to position themselves, you want to note how their ability is to follow your commands. You want to be able to assess the patient's vital signs against the baseline to note any changes, and you want to note any changes in the patient's neurologic status or loss of consciousness, and that must never be ignored. You don't want to assume something about a patient in the fact that when they have those changes come about, that they're for any reason other than a deteriorating level of consciousness. Even if drugs or alcohol are involved, you don't want to make that assumption. You simply want to report the changes that you note. As far as their deteriorating status, the signs, like we said, sudden irritability, lethargic, kind of slow to move, kind of slow responses, a slowed pulse rate, slowed respiratory rate, a change in their level of consciousness, how they respond to you. You want to make sure that they maintain an open airway. You want to move the patient as little as possible. It is possible that you stop the radiographic procedure and get medical assistance as soon as possible, and you might even monitor their vital signs. The patient could be going into shock. By definition, shock is a term that indicates a failure of the circulatory system to support the vital body functions. And there are different types of shock. When they talk about it, there are actually stages of it. There's a compensatory stage, a progressive stage, and then there's an irreversible stage where you can kind of turn around the fact that they're going into shock, and potentially halt that progress, but there comes a point where you're not able to turn that around. As far as the different types of shock, we have neurogenic shock, which is caused by spinal anesthesia or damage to the upper spinal cord. You have hypovolemic shock, which hypo tends to imply low. Hypovolemic is low volume. This tends to occur when there's a loss of blood or tissue fluid. That can happen with burn victims, victims that were stabbed, or with a lot of blood loss. They can go into hypovolemic shock. Cardiogenic shock is caused by different cardiac disorders, including a heart attack. And vasogenic shock is caused by sepsis, deep anesthesia, or anaphylactic shock. And anaphylactic shock is typically the most common one that we see in the radiology department. This occurs due to contrast media reactions. If this happens to your patient, you want to closely monitor them. Some symptoms that they could have would be urticaria, which would be the presence of hives, laryngeal edema, which is their throat swelling or closing off. They could go into shock, and they could even go into cardiac arrest. So anaphylactic shock is not something that we want to mess with. We want to note the changes that are occurring and get emergency help as soon as possible. I would also tell you that when you inject contrast into a patient, you never do that with the door shut. You always have the door open so that if anything goes wrong, you have the capability to yell to someone passing by, or that someone has the capability to hear you a lot better with the door open than with the door to the room shut. Some common signs and symptoms of shock would be a patient becomes very restless, they get apprehensive, or they have a lot of anxiety all of a sudden. They can have tachycardia, which is a rapid heart rate. There can be a drop in their blood pressure. They can exhibit pallor, which is cold, clammy skin, and they tend to get very pale in their complexion. How can you prevent shock? You want to try and have the patient maintain a normal body temperature. You can give them blankets to keep them warm. Typically, a patient will start to shiver when they're going into shock. You want to avoid overheating the patient, and you want to try and help the patient manage their pain or reduce the pain if possible, reduce their stress or anxiety levels. Sometimes simply talking to the patient, telling them that everything's going to be okay, help is on the way. Ask them about something completely distracting, like about their children or their spouse, or the kind of car they drive. Something to get their mind completely off the present situation can sometimes help reverse or prevent shock from advancing. As far as anaphylactic shock, it is a type of vasogenic shock. It is the most common type of shock that we encounter in medical imaging because of our contrast media. Some signs and symptoms, they have to be monitored as the routine procedure with contrast studies, meaning you want to note if the patient exhibits hives, you want to note if they become anxious, or they start swallowing very hard, or they start to feel claustrophobic sometimes and feel the need to get up. Any type of signs that go on when you are injecting contrast into a patient, you want to alert a physician or someone in the department immediately and get help. A lot of times we have diabetic patients that come in. We try to treat the patients that are diabetic, especially when they have fasting exams. We try and make them first thing in the morning so that they're not having to go long without their insulin. But a healthy patient tends to adjust their own insulin production and excretion in order to meet the carbohydrate demands of the body. Patients that have diabetes, though, can either be treated with insulin shots or diabetic medications, and they have to actually adjust their diet to balance their insulin depending on whether they are type 1 or type 2 diabetics. Diabetic patients can either experience hypo or hyperglycemia. If we start with hypoglycemia, hypo implies low. So hypoglycemia is where there's excessive insulin present in the body. This can happen if a patient takes their normal dose of insulin and does not eat because they have an exam preparation that they're doing. So if they don't eat, but they still take their insulin, then there's not enough food to act on the insulin, so they have excessive insulin present in their blood. Some signs of insulin, patients that are going into insulin shock, they're intensively hungry, they're weak, they're shaky, they can sweat excessively, they can be confused and irritable to the point of mild aggression or hostility. They often recognize these signs, the patients do, and they need a quick form of a carbohydrate, or they can take a glucose tablet. If they don't have glucose tablets, then we can give them any form of a carbohydrate. We could give them orange juice, and a lot of times they'll add a spoonful of sugar to it, a sugary soft drink like a Coke, Pepsi, something along those lines. Any kind of candy bar or any form of a carbohydrate can be consumed because we just need something for the insulin to act on. The opposite end of the spectrum would be hyperglycemia, and this is a condition where there's too much sugar in the blood, and this is typically associated with diabetes. This condition tends to develop gradually over a period of hours or days, so it's not typically something that technologists will notice as quickly as hypoglycemia. A lot of times these patients are excessively thirsty, they have a lot of urination, and they have really dry mucosa, like a dry mouth, dry throat. They tend to have rapid, deep breathing, and they're very drowsy and confused. When this happens, insulin is required, otherwise it will lead to a diabetic coma if it goes untreated. The problem is that we don't have access to insulin as readily as we would have access to orange juice or sugar or soda, candy bar, something like that. So if this is the case, the only way to treat hyperglycemia is to get the patient insulin. Patients can also exhibit respiratory distress. Patients that are asthmatic, typically they can exhibit respiratory distress. A lot of times patients come to radiology and the asthma attacks can be triggered when they're exposed to a stressful situation. Asthma is a chronic condition. Patients can get very wheezy while they're in the department. They have an exaggerated respiratory effort when they're trying to breathe. But most asthmatics carry their own inhalers. And if you know your patient is asthmatic, you want to make sure that they bring their inhaler in the room with them so that if they start to experience an asthma attack, they're not having to go out to the dressing room to find their inhaler to treat themselves. Okay. Choking would be another example of something that could happen in the department. Sometimes I've seen patients choke on a hard candy they might have been eating or choke on the gum that they were chewing and they accidentally swallow it. So the universal sign for choking is typically some kind of hand gesture to the throat. A lot of times these patients will be embarrassed and try to get away so that you don't recognize they're choking. If you do happen to have a patient that's choking, you want to be able to perform the Heimlich maneuver. You will be shown all of these things when you take your CPR class, but the Heimlich maneuver, typically they will tell you to recognize the universal sign for choking, and then if the patient is conscious, there's one way to treat it versus if the patient goes unconscious. So when they are conscious, you want to come behind them, you kind of ball up your fist and put it underneath their xiphoid process, and you kind of want to pull your hands in and up to dislodge anything that might be stuck in their throat. If the patient is pregnant, there are other modifications that are done for that, as well as for infants and children versus adults. And these are all things that you will learn in your CPR class. If the patient has an obstructed airway and you can see the object visible in the mouth, then you can perform a finger sweep to remove that object once it's dislodged. If they're unsuccessful in dislodging it, then you can begin CPR to actually force the obstruction up and out of the airway. You want to check the mouth repeatedly for the obstruction before each set of ventilations that you do to the patient. So if it's there, you don't accidentally use the ambu bag or blow it back down the patient's throat. CPR, again, you will have an entire class on this, a 4-hour training that includes CPR, AED training, Heimlich maneuver, both for adults, children, and infants. Medical imaging professionals have to be familiar with the institution's protocol for cardiac emergencies. I can tell you that radiologic technologists also have to maintain their CPR certification at all times while their license is active. Okay, we have to be familiar with all the skills that are required for CPR, and you have to maintain those skills as long as you maintain your radiology license. If you have a patient that experiences cardiac arrest and you are in a hospital setting, that's probably one of the easiest and best chances of survival for the patient, because all you would be required to do is enact a code. And once you call a code in the department, an entire team comes in to care for that patient. So recognizing how to do CPR, once you've been trained to do that, it's something ongoing that we have to maintain our skills in that certification. CPR has to be initiated immediately once you verify that cardiopulmonary distress has happened. And we have, instead of the ABCs, we have the CABs of CPR, which the first and most important thing would be to administer compressions, check the airway and make sure that it's open, and then lastly, we worry about breathing or ventilating the patient. Compressions are definitely the most significant aspect of CPR. When you take your CPR class, you will be also trained in the AED, which is an automated, I know the book says automatic, but I don't want you to think that it does it on its own. So it's automated, meaning it tells you what to do and when to do it. So the automated external defibrillators, you should always be mindful of where they are in your facility. Not to mention, you should be mindful of where they work. Most government buildings have the AED. Most parks and rec departments have an AED. There's not too many places you can go now where you wouldn't be able to find an AED. And these have become very valuable in saving patients' lives. They are used for ventricular fibrillation when the heart is kind of quivering. There are fully automated and semi-automated AEDs. You want to become familiar with each type, and that is something you learn in CPR. You can interrupt CPR to use an AED. It is more beneficial for the patient for you to use the automated external defibrillator. If it would help the patient while you're performing CPR, then CPR should be stopped. It's considered a standard of care with, in most situations, CPR is considered a standard of care, and the time of the AED intervention is critical to the patient's survival, meaning the quicker that you can enact utilizing an AED, if it would assist the patient, the more chance of outcome that patient has of surviving that incident. A cerebrovascular accident or a stroke, this is where that happens in the brain. It is commonly called either a stroke or a brain attack. It's more likely to occur in older patients over the age of 75, but it can occur in any adult. It can develop either gradually or suddenly. Most of the times there are some kind of warning signs, whether there is a temporary loss of consciousness. Sometimes they kind of fog out for a period of time and then come back and don't really know, can't really explain what they were doing in that time frame where they're just kind of spacing out. If a patient that is having a stroke does lose consciousness, you have to start CPR. And patients that are having a stroke should be placed in a recumbent position or lying down as soon as possible. A lot of times when patients come in with a suspected stroke, they will fast track them through the ER because they have a limited time frame in which they can give them medication, which is typically called like a clot buster. It is it breaks up the clot that is formed that has caused the stroke, and the quicker that they can give that medication and break up the clot, the better the chance the patient has of not only surviving the stroke, but regaining whatever was lost as far as function. Typically, some of the things that you can do to test if a patient or someone you know is having a stroke, it's called an acronym of FAST. F stands for you want to test if there's any facial weakness. You want to make them smile and make sure both sides of their smile are equal, not one side is drooping. The A in FAST stands for check their arm weakness, like raise their arm up and drop it and see what happens to it. Do they attempt to control it or does it just immediately drop? The S stands for speech, meaning you want to talk to them and ask them to answer questions for you. Ask them what their name is. Ask them what day of the week it is. Who's the President of the United States? And listen to how they answer you. And then the T stands for time, which time is of the essence. If you truly think your family member or a patient is having a stroke, seek medical help immediately. If you think your patient is having a stroke, then you call a code or a rapid response immediately, because the quicker that patient gets treated, the more likely they regain full use of whatever they're about to lose when they have the stroke, whether it's paralysis on one side or both sides. But the quicker you enact those procedures where they can give them the medication to break up the clot, the better it is for your patient. Some minor medical emergencies that we might encounter would be nausea and vomiting. Sometimes when we give the patient contrast media, they will feel sick to their stomach and actually vomit. Epistaxis, which is pretty much a nosebleed. Vertigo, which is dizziness, and syncope, which is fainting. Patients can experience seizures in the department. A lot of times, if a patient is about to experience a seizure, they will have an aura that they go through where they'll get this really weird sense that something's about to happen, and a lot of times they can warn you that that's going to happen. Patients might fall in the department. Burns could be something that happens in the department. Again, anytime there's a burn, you always are worried about infection because now you've broken down the body's defense of skin as a layer of protection. So when you burn that skin, patients are very susceptible to infection. As far as wounds, a lot of times we have to be mindful of the dressings on the wounds and make sure that they're not saturated with blood or that stitches have come undone. Things have been moved or dislodged. Like, you just want to make sure that their wounds are intact. You want to look at the dressing when you get the patient and see how soaked it is with blood or how saturated. And these are kinds of things that you always want to evaluate your patient when you first get them, so that if anything changes, you're aware of that and can pass that information. Epistaxis is a nosebleed. Typically, it is not life-threatening. You want to lean the patient forward and pinch their nose and keep them upright. You never want to lay the patient's head back, because what will happen is the blood will run down their throat and they have the potential to choke, and it also typically makes them very sick to their stomach. If bleeding persists, you want to apply moist compress. And if it hasn't stopped in about 15 minutes, then you really need to get someone else with a higher level of training in there to help you. But most of the time, that bleeding will stop within that 15-minute time frame. Vertigo is when the patients experience extreme dizziness. Typically, it can be a precursor to syncope, which means they're about to pass out. If a patient experiences vertigo, they should be assisted to either a seated or a recumbent lying down position as fast as you can. And you want to watch for orthostatic hypotension and vertigo when you sit a patient up from a recumbent position. Remember that orthostatic hypotension is when you get a patient up too quickly, their blood pressure actually can drop and they can pass out. So you want to be mindful when you go to move a patient, you move them slowly and very methodically. Syncope literally means fainting. The good thing about syncope is that it's self-correcting. It's just a temporary state of shock and results as a lack of blood flow to the brain. Most of the time when a patient passes out, they come to on their own within a few seconds. The biggest thing you want to do is try and increase blood flow to the head. So maybe you drop their head down between their knees so that the blood flows back, or you tilt the table backwards so that the blood flows back into their head. Again, you want to lie that patient down. Patients exhibit seizures. A lot of times they'll have a change in their level of consciousness. It's typically a symptom of another underlying condition. You want to make sure that you note the event in the chart, note what the patient was doing at the time the seizure occurred, how long it lasted, what you did to keep the patient safe. It can begin with little or no warning. Sometimes they'll feel an aura, sometimes they will not. But the biggest thing is you just want to keep the patient safe. Attempt to keep them from hitting their head by placing a pillow underneath their head. There is no such thing. Do not put anything in the patient's mouth. I guarantee you they will not swallow their own tongue. You just kind of stand by and wait until the event is over, and while it's going on, you make sure as best you can that they are not harming themselves or injuring themselves. But patients that are having seizures are extremely strong, and you are not going to undo anything that happens during a seizure. After the fact, absolutely, but during it, it's not going to happen, so don't even waste your time. Don't put the patient in that kind of danger. How you care for the seizure patient, again, prevent them from injury if possible. As far as securing a patient, I would tell you don't. If you can have them sit on the floor or lie on the floor and put a pillow under their head, that would be ideal. But sometimes you don't even have that much of a time frame. Always call for assistance immediately. Protect the patient's privacy if at all possible. Put nothing in the mouth, not your fingers, not a bite stick, not a tongue depressor, nothing. As far as removing dentures or foreign objects, I would tell you don't. Don't you dare put your hands near their mouth, because when they clench down, there is no getting that open until the seizure is over. The best thing you want to do is just try and keep them safe and make sure that they maintain an open airway. Don't finger sweep. You can put a blanket or a pillow under their head to keep them from injuring themselves. You want to observe the seizure. Like I said, what was happening when it came on? How long did it last? Do you notice it more on the left side being affected, or right side, or both equally? Once the seizure is ended, you want to place the patient in a Sims position, which means lying on their left side with their right knee bent. And you want to keep their face down so that if they happen to vomit, it will roll out of their mouth and not cause a choking hazard, because a lot of patients, when they're done seizing, they often will vomit. In conclusion, you want to attempt to recognize emergency condition and act appropriately all the time. You want to ask for assistance, meaning call a code, call for help, call for a rapid response, let somebody know what is going on in that emergency. You want to maintain competency with basic skills. You have to be CPR certified and be able to use the AED. You always want to use common sense in an emergency situation. Okay. Um, that concludes chapter 20 on medical emergencies. Please do make note that we do encounter medical emergencies all the time in radiology. We do have patients where they'll come in and potentially be fine and go downhill while they're in the department. Patients do fall. We do see all types of patients. Patients can be in the department and have a stroke or have a cardiac arrest. There's all kinds of things that can happen with a patient. Please do not think that just because you work in a hospital or you work in an outpatient center that you won't experience some of these things, because you absolutely will. Okay. Please make note of any comments or questions that you might have that I can address during our next meeting. And until then, I hope you have a great evening and take care.